So lower extremity anatomy. Can we maybe turn the lights down? I don't know if you guys can see it, but I can't. So this was prepared for physicians who were coming to a PVD course, but it works. They're all angiographic pictures. But this is looking at the abdominal aorta. You can see where the renal arteries are pointed out. The renal arteries are retroperitoneal structures, so although on the angiogram here it looks like it's coming straight out from the aorta, if we were going to look down at the aorta, they're really coming back towards the back, so off at an angle. So to get proper images, we do contralateral views or angulated views. Below the kidney arteries is the renal or the infrarenal abdominal aorta. As we'll probably talk about, that's the most common location for aneurysms. That's what we do EVAR for, or endovascular aneurysm repair, stent grafting. Then the aorta bifurcates into the common iliac arteries. Okay, so the aorta splits down there. You have a right, you have a left common iliac artery. This is if we're looking at the patient. And as we go a little further down, the common iliac arteries split again into the internal and the external iliac arteries. Hypogastric artery and the internal iliac artery is the same thing. Surgeons call it hypogastric artery. Cardiologists call it internal iliac arteries. Same thing. It's amazing how many physicians come here to train and don't realize that. But once again, you can see going from the top, the common iliac arteries split into the internal iliac arteries and the external iliac arteries. So the internal iliac arteries dive deep into the pelvis, supply everything in the pelvis. The external iliac arteries keep going down towards our groin and become the common femoral arteries. And they become the common femoral arteries as they pass under the inguinal ligament. Okay? So if we go up the other direction from the common femoral artery, as we go under the inguinal ligament, that's where it becomes retroperitoneal. Okay? So if you're looking at a patient, the groin's anterior, but the aorta is posterior. So the iliac arteries, we look at it often on an angiogram and it looks like it's just going straight up. Obviously not in this patient. But they also got that right to left tortuosity, but it's going from an anterior structure to a posterior structure. Does that make sense? Mm-hmm. So it's diving. So what you guys may deal with is the retroperitoneal bleeds, the retroperitoneal hematomas. I don't have a pointer, but this artery here, it kind of goes like this and goes up. There's another one on the side, is the inferior epigastric artery. What that artery is actually doing is coming off the common femoral artery and kind of wrapping under the inguinal ligament, if you will, going like that. So this is our angiographic marker of the inguinal ligament. So everything above this is retroperitoneal. Does that make sense? So when we're getting access in the cath lab, we always put a little clamp on the patient and do a little cine to look at the femoral head. Okay? And there's a couple reasons for that. Most times the inguinal ligament is right at the top of the femoral head. And also the femoral head, so that's one thing. At the bottom of the femoral head is where, and we'll talk about this in a second, the common femoral artery splits into the deep and superficial femoral arteries. Okay? So above the femoral head, you're probably retroperitoneal. Below the femoral head, you're getting into one of these arteries, you're not in the common femoral artery. Okay? So when we're trying to get access in the cath lab, we want to get it basically over the femoral head to prevent bleeding either from here or AV fistula if we stick these arteries down here, or pseudoaneurysm. Also, when we're getting hemostasis after the procedure and we're holding pressure, if we stick up here, there's nothing really to support it. You're just pushing the artery out of the way. If you stick here, we push. You got the femur behind it, the head of the femur. So you can compress it between your hands and the femur. Does that make sense? Mm-hmm. Questions about retroperitoneal bleeds? Sorry, let me just make sure this is nothing. Oh, God. Wes is asking if he can help. Please. But he should be here. Should I scold him for not being here?
Sorry.
I know. Sorry, guys.
Tell him that's his only excuse for not being here.
Yeah. So, once again, we got the common femoral arteries kind of right over the femoral head. As we go below the head of the femur, we got the profunda, or deep femoral artery, and that artery's going really to the hip, supplying the head of the femur, hip joint. And then we have the superficial femoral artery, which is what we're stenting most often in the cath lab when we talk about stenting, PVD. Superficial femoral artery is the longest artery in the body. It really goes from the groin to the knee. And we'll talk about that more. As the superficial femoral artery comes down towards the knee, you know, you can't see it angiographically or in x-ray, but you have the adductor canal where the artery kind of starts to dive from a medial structure, go behind the knee, cross over the femur, and that's where it becomes the popliteal artery. Okay? So, most times when a patient has a fem pop bypass, it's from the common femoral artery to the popliteal artery, somewhere kind of above the knee is our ideal location. So just something to remember with that. If you're sending someone for a fem pop, if they can get above the knee popliteal bypass, the patency is much better than if we had to go below the knee. So you do have fem below the knee bypasses sometimes. And if we focus on the right side of the screen, the popliteal artery comes down below the knee, and then these are the tibial arteries. So the popliteal artery splits, and you have an anterior tibial artery kind of going out lateral, so far right there. And then the tibial perineal trunk comes down and it bifurcates into a posterior tibial artery and a perineal artery. Okay? So the anterior tibial artery is the artery that goes down to the foot, and you can feel on the top of your foot comes the dorsalis pedis. The posterior tibial artery is the one you can get the pulse behind, the medial malleolus. Okay? And those arteries are the arteries we're going to check pressures in when we do ABIs. So we'll get to that in the next slide set. Any questions on anatomy? Alright, let's see. I'm afraid to close this, but yeah.
Corey has on the phone too. I'm pretty sure you can hear her.
Hey Corey.
Hey, good morning.
There we go. Questions, please speak up. We'd like it to be interactive. Anything PAD is fair game. If I don't know the answer, I'll make it up. So I gave this talk a few years ago down at the Arch conference. We might not talk about every slide, but let's get to. So, why is PAD so important? Really, what we talk about most is stenting arteries in the leg and treating claudication, but that's really not the importance. I mean, when you're doing that, most times you're just treating claudication, which is a symptom. You're making people feel better, their lifestyle better, which is important. But when we screen for PAD, it's a marker of multi-system disease. So if you have blockages, and you guys all know, in your legs or your carotid arteries, you have it elsewhere, your heart and so forth. So if you look at the figure upper right, the worse your ABI, the worse your survival. So it's just not a marker of claudication through your legs hurt. If you have bad ABIs, you're going to live less long. So really, it's important to get those ABIs in patients. It's important to do the penile pulses, because if you're finding PVD, it's kind of like another risk factor. It's just as important as doing a coronary calcium CT scan or checking cholesterol and diabetes and so forth. 5 to 10% per year mortality, 2 to 4 4-fold increase in total mortality, 6-fold increase in CAD mortality. So we all have those patients that come to us and they say, why are they here? It's just like a screening consult. But, you know, they have family history of coronary disease and they want to be screened. Well, this is an important way to do it. Check your pedal pulses. If you don't think you're getting good pulses, get ABIs. You know, this could be a marker. Everything else, normal, but you got to have normal ABIs. You got a reason to treat them aggressively, you know, as far as their cholesterol and everything else.
Are regular ABIs okay in that setting? Just, or would we need to walk them?
I think that's a great question. So what she's getting at, and we'll talk about a little bit in a few slides, is patients who have symptoms of claudication but normal rest ABIs, you're not done. You got to do exercise ABIs. So I think as a screening test, rest is okay, but you may be missing people that have asymptomatic or subclinical EAD.
So is decreased pulses available diagnosis then for ABIs?
I think so.
Is it?
I think so. So looking at the prevalence of PVD as we get older, you can see it increases as we get older, both in men and women. This is the overlap. So, you know, the different colors are worsening ABIs, but you can see if your ABI is less than 0.8, you're much more likely to have carotid disease, an abnormal EKG, an abnormal echocardiogram. Once again, systemic disease. The overlap, you know, so usually it's not isolated disease. So if you have the patients coming in with claudication, they have normal vascular exam, it's probably good to start thinking about other things and screening for other things and definitely treating. If we look at patients who have symptomatic PVD, lower extremity PVD, so claudication, if we take 100 patients, you can think of this as percentile. Actually, let's start with 500 patients. So you can see that of 500 patients with peripheral arterial disease, 300 of them are not going to have symptoms. So a lot of times patients come in, they don't feel anything at all, or they tell you something weird like their legs get tired, or you don't always get that classic, my calves burn when I walk, it gets better when I rest. So that's why it's important to screen, that's why it's important to do the vascular exam. Of the 500, 100, 1/5, 20% will have the classic symptoms that we usually think of. And then another 20% never present to a physician. So if we go down to the next level, we can break their outcomes into local outcome and systemic outcome. So let's start with systemic outcome on the right. You can see that 5 to 10 of these patients will have a non-fatal cardiovascular event. This is in 5 years. 30% will die. And you can see what they die of: cardiac events, cerebral events, other vascular events, and then the minority non-vascular events. So of your 100 patients who present with claudication, 30% will be dead in 5 years. 50 to 60% to the right will be alive without a new cardiovascular event. If we look at the outcome in the leg, most patients with claudication, their symptoms are pretty stable. 5 years, 75% of patients are going to have the same claudication they do the day they met you. 25%, 1/4 will get worse. And 5% will require an intervention, and 2 will require major amputation. So the take-home message here is, looking at the 75% stable, the most important thing is not, you know, getting these patients to Goldstein or Goldstein so they can put a stent in their legs. It's really, on the right, treating the systemic outcome, because 30% are going to die. Critical limb ischemia, I have another talk about. That's a different thing. So when you think about lower extremity peripheral arterial disease, you know, think about claudication. Those are the patients, their legs are fine, they have no sores or ulcers, they just get pain when they walk, they can't do the things they want. Critical limb ischemia is kind of on the other end of the spectrum. Those are the patients with lower extremity ulcerations. They need something done or they're going to lose tissue or start getting amputations. So, incidence, prevalence of PVD as we get older, once again, you can see both men and women. It gets almost 25% of men and women age 75 or greater have peripheral arterial disease. On the right, you can see patients with no symptoms in yellow, or whatever that color is. Patients with atypical symptoms, red, are the majority. The minority are the patients that present with the classic symptoms. Okay? So once again, not good enough to just say, hey, you get burning discomfort in your calves when you walk. Briefly, you know, they complain of fatigue, aching, numbness, pain, tired legs when they walk. You want to ask about any wounds. You know, the next, people with severe peripheral arterial occlusive disease, their pain is better when they're upright or when their legs hang in a dependent position. So sometimes these patients come in and say, well, you know, I got to sleep with my leg hanging off the bed. That's because gravity's helping the flow. You know, they put their leg up and the perfusion's worse, it starts to hurt. I think you mentioned something about mesenteric ischemia or something, but patients who come in with the weight loss, they don't want to eat or they're scared to eat. That's called cytophobia because it hurts when they eat. They get abdominal cramping and so forth, kind of like when you're a kid and you go swimming really quick after you ate lunch. That's because of mesenteric angina, basically. And then we'll talk about aneurysms, but first degree relatives should be screened. We don't all do this. The facilitators know, most of them in my clinic, that we should get blood pressures in both arms. If you have a gradient between the right and left arm, that's a sign of upper extremity peripheral arterial disease. Usually left subclavian is most common. We want to listen to the abdomen, neck, groins for bruits. Palpate the abdomen for aneurysm. That's pretty insensitive. It's better to screen the appropriate people. You know, we want to feel the pulses, femoral popliteal, posterior tibial dorsalis pedis. This I'll admit I don't do, but the elevation pallor and dependent rubor is basically what we just talked about. If you have someone, if you hold their leg up for, you know, a minute or so, the leg will get pretty pale just because now they're going uphill, the perfusion, plus a stenosis, the perfusion's poor, they'll get pain, and they'll become maximally dilated, the microvasculature. Now when you drop the leg down in a dependent position, they get really red because everything's dilated. Now the blood's getting down there. That's the dependent rubor. You know, look at feet for ulcer. Nobody likes to look at feet, especially our patients' feet. So, a little bit to Danita's questions. In patients with suspected PAD greater than 70 years of age or greater than 50 with diabetes or smoking history, it's reasonable to get a ABI. All new patients with PAD. We'll talk about pulse volume recordings, TBIs, and segmental pressures. So this is kind of a baseline. My protocol after I do a peripheral intervention is to get the ABIs with rest and exercise, as well as a duplex ultrasound of the segment or the vessel I intervened on every 6 months. And it's kind of random how long I do that for. I usually do it for several years. If I've documented for several years that there's no change, then I start doing it annually. Some patients I know I'm never going to want to intervene on again, or they know they're not going to have another intervention, and those you might follow symptomatically. So this is most important. So please ask questions. So the way we do ABIs is first we check a blood pressure in both arms. And we take the systolic pressure in the higher arm, so the higher systolic pressure, okay? And that's our denominator, okay? And the reason is we're really trying to, with ABIs, determine is there a pressure gradient between the aorta and the ankle, okay? Well, we can't measure the aortic pressure, but our arm pressure is a surrogate for the aortic pressure, okay? So if it's 100 in the right arm, but 50 in this arm, well, maybe there's a subclavian stenosis. Using 50 is not going to be accurate. We want to take the highest one, and we're making the assumption that the highest one, there's no stenosis, there's no gradient between the aorta and the arm. Does that make sense? And then we check pressures in both ankles. And the final ABI, you'll always see if you dig into the report, you'll get an ABI for the dorsalis pedis, you'll get an ABI for the posterior tibial. But the final result is the higher of the two, okay? So to make it easy for me, let's say this is 100, and this is 100, and this is 50. The result is 100 divided by 100, or 1, right? If this is 100, this is 50, and this is 70, the result is 0.7. We took the highest of the posterior tibial or dorsalis pedis on the right leg compared to the highest. Okay, some people often make them say, well, it's right arm to the right leg and left arm to the left leg. No, it's the highest of the arms to the highest on each. So you get an ABI on each one. Make sense? So, it's easy to remember that normal is about 1, okay? But, there's higher resistance the further we get from the heart, so really a normal value is kind of 1.1 to 1.2. But I like to keep it simple, so I just remember 1. And I explain it to patients, it's a ratio, it's not really a percentage, but if their ABI is 0.5, it's easy for patients to understand that, well, you're getting about 50% of the blood flow you should. You can see 0.9 to 1 is starting to get below normal. Less than 0.9 is, and these are rest values, we'll go over exercise, is definitely abnormal. 0.5 to 0.9 is single level vascular disease, so maybe they have an SFA stenosis. I don't think about this too much. It's either, once again, I keep it simple, either abnormal or normal. But you can go on down. Less than 0.5, you probably got multi-level disease. This isn't so true. I got patients with ABIs of 0.9, and they have intermittent claudication. Or they may have normal rest ABIs, but when they exercise, they have intermittent claudication. 0.3, they're usually having rest pain that, when they're just laying in bed. Less than that, they probably have starting to have tissue loss. So this is an example of if you order segmental pressures. And where this is helpful is if you want to localize the level of disease. So this isn't a great example because the patient's ABIs are normal, but let's say, once again to make it easy, the arm pressure is 100, the high thigh pressure is 100, the low thigh pressure is 50. Where would the blockage be?
That's okay.
Yeah. So, we said 100, 150, so somewhere between here. So, high thigh to low thigh, we have a pressure gradient, so somewhere in the SFA. If it's 100, 100, 100, 50, now it's popliteal. And then you can, right? Pretty straightforward. So, if you just order ABIs, you're not going to get segmental pressures. If you order ABIs with segmental pressures, you get it, and it can help localize Okay, and that's something we do planning for procedures. So I think you guys got this. If you look at the bottom half of the chart, you know, you go between the segments where you see the pressure gradient. You may see pressure gradients in a couple different levels, and you got multi-level disease. All right, this is the most important thing. So, patient comes in and complains of calf discomfort when they walk. Let's say they can walk a half block and then they got to stop and rest. And you get ABIs at rest, and their ABIs at rest are normal. I know you all know that doesn't mean you're done, but a lot of referring doctors think, well, shit, there's nothing wrong then. The important thing is when you, and then I'll read through the slide, but when you walk, you require much more blood flow to your skeletal muscles, so the flow increases up to 10-fold. Okay, so my simple analogy is the garden hose. You got your thumb over it, but you just barely have the water on. Well, your thumb is not really creating any obstruction. The water comes out fine. Now, if you turn the spigot up all the way, now your thumb over the end, you're trying to get a lot more flow through that narrowed orifice. Now you have the water shooting across the yard. The reason is now you've created a pressure gradient, okay? So delta P is that pressure gradient. The change in pressure equals flow times resistance, okay? The resistance doesn't change. The resistance is your lesion, but your flow does. So when you walk someone on the treadmill, your flow goes up 5 to 10-fold. Now that stenosis that didn't create a pressure gradient at rest is creating a pressure gradient, so the pressure drops when you check them. Does that make sense? Mm-hmm. So the way we do it is we get it at rest, then we get the patient on the treadmill, we walk them for, you know, whatever the protocol is, and then we jump on the bed real quick and check their ABIs. Okay? So patient with symptoms, normal rest ABIs, you got to get exercise ABIs. So I always just order rest and exercise. Now, we used to have a protocol, and it's kind of fallen off, but that the vascular techs would understand that if your rest ABIs were abnormal, they didn't need to go on. You don't need to go on and get exercise ABIs. If you got a gradient at rest, you're going to have a gradient at exercise. But still, if you order them, you'll see you get both, even though the rest ABIs are 0.7 there. Does that make sense? I think that's most important. You also get, you know, they'll report their symptoms, so you'll see if they have claudication when they walk on the treadmill. You can see how long it takes for their pressures come back to normal. Sometimes they don't. You can see how much they drop. And sometimes, you know, they have angina. You diagnose coronary disease. Here's a case of a patient. If you look to the bottom line, the patient's ABIs at rest are 1 point. So let me set this up. This is a 70-year-old male, comes in. He can barely get out to his, he lives on a farm, he has a long driveway to his mailbox, but you know, by the time he's at his mailbox, he has to stop and rest for several minutes because he has calf pain. After he rests for several minutes, he can walk back to his house, but once again, by the time he gets back to his house, he's limited by his calf pain. ABIs at rest, excuse me, are 1.2, both sides, so normal. So you stick him on a treadmill, and you can see what happens at rest. His blood pressure and his pedal pulses is 120. And then he exercises, and then after exercise, they jump him on the gurney, they check, you know, the first blood pressure check and his pedal pulses is at about 1 minute, and it's dropped to 80. And then over the next several minutes, it starts to come back up, but never quite reaches his baseline. And there's what he had. All right? So once again, I know I've said it several times, with those narrowings, at rest he's getting enough blood flow. It's not causing symptoms at rest. It's not even a pressure gradient at rest. His ABIs are normal at rest. But he exercises, now you're trying to get several fold more blood flow through those stenoses, and they become hemodynamically significant. It's really the same thing we do for a cardiac stress test, right? So, just to diverge a little bit, but when we do an exercise stress test with nuclear imaging, the nuclear isotope is absorbed by the myocardium, and then we can tune our cameras to that wavelength of energy, and we can see where that's gone in the heart, where the perfusion is. So we do it at rest, and then we exercise the patient. So if at rest everything lights up, and at exercise half the heart's not lighting up, the artery that went to that probably has a hemodynamic significant stenosis, right? We do dobutamine, we're stressing the heart. If we do adenosine, it's a vasodilator in the microvasculature. It's really flow differentials that we're looking for to create a gradient. Make sense? Sorry, one second, let me just make sure with this. Corey, Dr. Pragy's texting me.
You have your
And he'll-
clinic at
Your
9.
clinic at 9.
I bored him already.
Hey, what about, often you'll get a TBI that's abnormal. What do I do with that?
With a normal ABI?
Yeah.
Well, so your pressure to your ankle is good, but now you're talking about toe brachial indices. So small vessel disease in the foot.
And I just look.
Ignore it.
Okay.
Well, I shouldn't say that. Don't ignore
Unless
it.
they have like a wound that won't get
It
better.
really comes into that's when we're looking for wound healing.
Okay.
Yeah,
Okay.
yeah, but that's small vessel disease in the foot, and a lot of times not much we can do about it. But when we're considering wound healing potential for an amputation or something like that, it might help us predict if they get a toe amputation, is it going to heal? Or are these guys going to end up with a 4 foot or more likely to beat KA? Partner, I'm just gonna. Hey, I'm giving a lecture. Can I call you back in a few minutes? Well, more like an hour. I'll call you back. All right. Bye. Sorry, that was Dr. Prangy. So, duplex ultrasound. So now we're talking about doing an ultrasound of the arteries. Okay, so we can step down the arteries and look at an ultrasound image of the vessel, but also the flow. Measure the velocities at different levels. So where is this helpful? So as I mentioned, a lot of times after I've intervened on a vessel, I'll use this to look at that vessel that I intervened on. So let's say an SFA and I got a stent in there. I want to look at the stent and see if there's restenosis. So I'm looking for a doubling of velocities. Let's say I've taken someone to the cath lab and they got this, it doesn't look terrible, but their ABIs are abnormal. I might stop at that point and get a duplex and try and localize. Is it the lesion in the left SFA or is it that one in the popliteal that's significant? Bypass grafts. So, unfortunately, depending on the surgeon, they tend to be bad on this. So I take over with, after somebody's had a fem-pop bypass, you need to screen that as vigorously as you would a stent. And the patency's better. So most times in the first 5 years, you're not going to find anything. But the important thing is once you find a hemodynamically significant stenosis, you got to jump on it. We just had one recently, and everything was done appropriately. The patient had it. There was a high-grade stenosis. We got him to the cath lab within a week, and the graft was gone.
I was going to ask, does it tend to thrombose faster
Yeah.
than the synthetic?
Yeah, the grafts do. So grafts and stent grafts. So stent grafts are basically stents that are aligned with PTFE, the same thing the surgeons use. Once it's just something different about them and not human tissue. Once they develop that stenosis, they tend to thrombose. So once we find a stent graft with a stenosis, a doubling of velocity or a fempop, we get them in the cath lab and see what's going on and fix it.
So you skip all the screenings, you just, like, you
Yeah.
don't get ABIs and stuff?
Well, I do. So somebody has a fempop. Let's say Mr. Jones has a fempop. He's going to come back at least every year for the first 5 years with ABIs, rest and exercise, and a duplex of that graft. Now let's say the ABIs are abnormal and he's got a stenosis in the graft. He's going to the cath lab. Let's say the ABIs are abnormal but the graft looks pristine and I find something in the popliteal. Well, that's a different discussion. That's outflow. It's not the graft, but it still does impact the graft. But does that make sense? So I'm the ABIs will let me know the perfusion to the whole leg, and then I'm going to focus in with the duplex. So Amy uses this quite a bit, looking at, that's different, looking at veins and so forth, but, surgical bypass. And I already mentioned this routine surveillance after popliteal bypass. Patients with claudication, you're doing your vascular exam, you're going to get your ABIs. If ABIs with exercise, I would just order that on everybody. So maybe I don't go into this but I gave one sentence to exercise therapy, and it's important. It should be available. It's not available yet, but very soon in our cardiac rehab, we will have supervised exercise therapy. So what that is, basically, better, a stent will give you more immediate relief of claudication, but long-term relief and probably better for the patient is exercise therapy. So what that is a period of time every day, let's say an hour, where the patient exercises till they're limited by their symptoms, rests, exercises until they're limited by their symptoms, over and over for that hour. Over time with exercise therapy, you'll recruit new collaterals, you'll get your muscles in better shape, and your claudication improves. Okay? The bad thing about exercise therapy is if you stop, you just fall back to baseline in short order. It's something you got to keep up, and that's a problem with humans. Exercise or supervised exercise therapy, which is more effective, is oftentimes not paid for, not available. But my point is, it is going to be available through our cardiac rehab here in PHI. Really any day now, I believe. Exercise therapy, pharmacotherapy. What I'm talking about here is silostazol. Okay, so that we'll talk about. So, just talking about medical therapy. So, really, patients should be offered or prescribed exercise therapy. Silostazol, the mechanism of action is not really understood, but then it doesn't help everybody. But in patients, it helps. They have about 50% improvement in their pain scale, their walking distance. So, the way I explain it, if you can walk a block, maybe you can walk a block and a half before you're limited. The main side effect is diarrhea, so patients can have diarrhea. If you stop the med, it goes away. The dose is 100 twice daily. Heart failure patients, we're a little hesitant to give it to you. You may give a decreased dose of 50 BID.
Is that okay to prescribe even for folks that are taking aspirin and Plavix for another reason, or Plavix and warfarin?
I do. Yes, it does have some antiplatelet effects, so their bleeding risk goes up. So it's not the same as
like triple therapy.
What we say triple therapy, but it is increased risk. So I explain that to the patients. But in my experience, It's not very effective.
Hey.
You know,
And
most
they
of my
have to-
patients are humans, so they want something done right away.
Right.
You know, so when you explain it to them, a lot of them who are really limited say, well, let's just take a picture and see what we can fix.
Right, because it's not fixing
Um,
the problem.
And I think another important point there is, yes, I can fix it, but the restenosis rate's very high. So these patients come back. So I tell them, you know, I'll fix it, but then you're stuck with me. You're going to come back every 6 months. I'm going to do these ultrasounds every 6 months. If you have re-narrowing, we're going to have to talk about going and fixing again. And the likelihood is, you know, a couple of these patients are going to have several interventions. I got some guys that just keep coming back, and it amazes me. They just want another procedure, but you know, they've had so many of this.
So speaking to that, like for our patients who have known coronary disease, I
I'm
mean, we
listening.
should be making sure that we're screening ABIs on most of those patients, so we catch it earlier, not later. I mean, is that,
I'm sorry, I was listening and I missed your question.
and so for our patients who have known coronary disease but no symptoms of claudication, I mean, would it be beneficial to do a screening ABI in those patients, knowing that they have risk for peripheral
I think
arterial
that's
disease,
a-
and then trying to catch it ahead of the game until they need to come to you for stuff?
I think it's a great question and one I think about from time to time, but
Because there's
you've
no
got,
guideline for that, I mean,
yeah, you've got your patients with coronary disease
and they're smokers and diabetic and, I mean.
and you're treating them maximally
Right,
and they have no claudication. So does it matter if their ABIs are abnormal at that point? In my mind, no, I'm treating them the same.
right. I'm saying more for like patient lifestyle modification. Like you have borderline ABIs and this will progress if you don't stop smoking or stop, even though we're maximally medically treated.
Yeah, I
mean,
think
it's
your
more
goal
like-
there is, hey, look, you also got this.
Right.
Shape up, buddy.
Right, kind of that's what I
Yeah,
was getting
I
at.
think that's very reasonable. Yeah.
Get paid for, that would be the only.
Yeah,
Right.
I mean, everybody's probably got decreased pulses a little bit.
Mhm.
yeah. I think, you know, sometimes you got that patient and they're on statin, they're on ACE, they're on aspirin, they're on plow. You're doing everything and they don't have claudication. You say, well, if I get ABIs, is it going to change anything? Not really. But your point is, yeah, you know, maybe
You
it's,
may convince them to check their blood sugar or
Yeah,
pay attention
it's-
to their
yeah.
blood pressure.
and it's another example for them, yeah. So I think there's no right or wrong
If
there.
there's a reason to check.
Yeah, I think either way. We'll just skip, I don't know what I got here, but you can see, this is an example. So on the left, going back to our anatomy slide, there's a high-grade stenosis in what artery? Don't look at the top. So we got, this is the
Aorta, right iliac.
yeah, so the right common iliac. So this is the right internal. Another name for the internal iliac artery is the,
Hypogastric.
yeah, this is the external. So this is a patient with a right common iliac. So where would you think their claudication would be?
Buttock or hip
Yeah.
pain.
Yeah, these guys may come in, and we see it several times a year where patients have had hip replacement, and they're, yeah,
I actually have.
and they actually have.
I have
Yeah.
a patient who needs an exercise ABI, I know, because his rest was normal and he's got this hip pain, but no other orthopedic issues, and he's a total vascular path. So I'm gonna like go downstairs and
Right.
order his exercise ABI. I'm literally gonna do that.
But I'm not kidding you. I mean, we see patients who've had hip replacements,
I still have that
and they say my hip still hurts, and we do, you know, you check their femoral pulse, and they don't have one. And you do, you know, you do a duplex, and sure enough, their iliac artery's occluded. So that's just a pre and post. I mean, that pretty straightforward to put a stent in, and these kind of things are very gratifying because the patients they can't walk very far, and you know it's literally it's a 20-minute procedure to put a stent there, and then they come back and they love you. So those are fun. And the patency of an iliac stent's pretty darn good.
for the higher flow.
Yeah. So nobody goes, or nobody should go to an aortofem or an aortobifemoral bypass anymore. I mean, that's a very morbid procedure. That's what you used to do for that stenosis. Patients are, you know, they get an ileus, they're in the hospital for a week, it's terrible.
Yeah.
And that, I'm not kidding you, it takes 20 minutes. All right, where is?
And again, real fast, it's aspirin Plavix for a month after?
Pardon me. That's a good question. So, there is not really, we aspirin and Plavix is based on data we extrapolated from the coronaries. So, yes, I do aspirin and Plavix for at least a month. Okay? There's some data from an old trial suggesting vascular patients who are treated with Plavix do better than patients treated with aspirin. So that was aspirin versus Plavix, not the two together. But for me, if I have PVD patients, and a lot of times I just leave them on both aspirin and Plavix. But I try and get at least a month out of them. These are big stents, and if you have to, you can stop them. So a good example is sometimes we have patients with subclavian stenosis. They need a lima graft. So we put a stent in the subclavian so they have good flow in the lima. I just put them on aspirin and they go to surgery, and I start the Plavix afterwards, and the stent stays open. So an iliac stent typically is going to be 10 millimeters compared to a coronary, which is typically 3. So they're bigger. They just, aspirin, if you need to alone, works. But try and get Plavix on everybody. Answer that?
So just to clarify, if you can leave them on aspirin and Plavix, that's the best?
I usually do, yeah.
Okay.
All right. Without looking at the big yellow print, what vessel is this?
Well, it's along the femur.
This is your first, this is a question, you're getting credit. SFA. Brilliant. All right, what is the artery distal to the blockage? Just below, downstream. Yeah. So as it starts to cross over the femur there, that's popliteal. So this is a common. So where would this person's claudication be?
Would it be in the calf?
Exactly. 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 What are those squiggly vessels coming off to the right and left of the vessel on the left side image that are gone on the right side image?
The collaterals.
Uh-huh. And why are they not there on the right side?
Because there's better flow in the main artery.
Yeah, exactly. So, I always talk to my patients about, you know, when you're a kid, or at least when I was a kid, I'd go in the woods and play with the stream, and I'd dam it up with rocks, and then the water would kind of find its way around. Once you remove those rocks, the water's going to go down the stream. It doesn't go around anymore. So that's what we like to see. You got all those collaterals, and we start way up here. And this is why patients, you know, their leg, the SFA is occluded and their leg's not falling off. They got all these collaterals, but I mean, look at the difference. That's what you want to see. You got a nice result and they immediately just dry up. I mean, they're still there, but the flow is going to go the path of least resistance. All right? That's the first rule of plumbing.
Yep.
Anybody know the first rule of plumbing? Danita should. Oh my gosh, you know it?
What was the question? I don't think I
First rule of plumbing.
First rule of plumbing. Shit flows downhill.
Oh, yeah.
That's what I was gonna say.
Right there. What do you guys, do you know it?
It rolls downstream.
Yeah, shit goes downhill.
Yeah. What's the second rule of plumbing?
You want to be at the top of the hill.
Exactly.
Yeah. Exactly. That's kind of the third rule of plumbing is the boss is the son of a bitch. So once again, this is bilateral what occlusion?
Common.
Yep. Patients used to always go for aortobifemoral bypass. And 90% of the time, maybe that's a little exaggerated, 80% of the time, this kind of lesion, pretty complex, we can fix stents. Probably takes a little longer, more like an hour, but it can get done. You can see all the collaterals on the left, including, for extra credit, what's this vessel coming off the aorta? inferior mesenteric artery. So he's got a huge collateral from his inferior mesenteric artery. You can see it, barely see it over there, but all these collaterals. All right. I won't spend much time on renal artery stenosis, so I'll give you the bottom line. The CORAL study was the most recent large study we had. Bottom line, renal artery stenting wasn't really associated with a decreased need for dialysis, minimal improvement in blood pressure. So, you know, when I first started here 15 years ago, we were doing lots of renal artery stents. I can't remember the last time I did one. So patients with renal artery stenosis, we treat them aggressively with medications, get their blood pressure under control. If they're on several medications and you can't get their blood pressure under control, their renal function's declining, then I think it's reasonable to go in there. And so the left hand is the most common type of renal artery stenosis, which is atherosclerosis. And it's usually an extension of a plaque from the aorta into the ostium of the iliac, of the, renal arteries, right? You can see, pretty obvious. The right-hand side is, usually happens in young women, sudden onset of high blood pressure. Starts with an F, yep. Yeah, fibromuscular dysplasia. So this is an abnormal growth of the artery, most times the inner lining of the artery, and it creates these little webs. The thing about this, intervention is indicated for these patients. So these are pretty striking. These are usually young women come in with, 20, 30 years old, really high blood pressure, unexplained. You find this, you balloon it, kind of tear those webs open, and their blood pressure, yeah.
So do you still get renal artery ultrasounds for secondary, as your workup for secondary hypertension?
Sometimes.
Like in a 29-year-old woman?
Oh, absolutely.
Yeah.
Young woman comes in.
I'm like, oh God, I've got one right now. I need to go image her kidneys.
Yes. I mean, this is usually young woman, high blood pressure. You should always do it. Yep.
Okay, yeah.
Yep. And it really is pretty. One woman stands out in my mind, but yeah, she was on several meds. We ballooned it, and she's on no meds.
Wow.
Enough for renal artery stenosis.
Hey, can we talk about EVAR too?
No.
I don't want to run out of time and not talk about that.
Are you kidding me? I hate talking about aneurysms.
I'm sure. I don't even know what time it is.
Yeah, you tell me when you guys get tired, because
No, this is great.
I'll just go on forever. Right, what kind of renal artery stenosis is this? A, atherosclerotic. B, fibromuscular dysplasia. Yep,
Ew.
there you go.
Wow.
Let's see what's in this lecture, and then I have a separate lecture. Make sure we cover the important parts. Right, so this person's alive, that person's dead. So let's see what we have here. Oh, good. Yeah, so an aneurysm, a true aneurysm, involves all three layers of the artery, right? So you got the intima media and the adventitia. Okay? You get lots of CTs where they call things aneurysms that aren't. So the definition, if you want to be a purist, is 1.5 or 150% the normal diameter. So the abdominal aorta below the kidneys is usually 2 centimeters. So 1.5 that is 3.
Mm-hmm.
So less than 3, but bigger than 2 is ectatic. Bigger than 3 is aneurysmal. So ruptured aneurysm, 75% mortality.
Gosh.
Yeah. So here's how I scare patients. Just kidding, but this is the truth. If your aneurysm ruptures, half those patients die before they get to the hospital. The half that make it to the hospital, half of them die. That's where you get that 75%. 13 leading cause of death in the United States. And I think we have more slides about prevalence. So, if you have an aneurysm one place, you're likely to have them other. So our protocol, if you have an aortic aneurysm we always get a CT, at least one CT of the chest, popliteal artery duplex, to exclude aneurysms in those locations, or vice versa. If they come to me with a chest thoracic aneurysm, we get an abdominal aortic ultrasound, we get the popliteal artery ultrasound. That, we do it on everyone. Now, do we find a lot of popliteals? No, but one day we will. But that's appropriate. And we'll talk, this is where it gets complicated. I don't know why this is so confusing, but it is. And we'll kind of go through this, but really focus on the Medicare approved guidelines. So men 60 or older, if you're a sibling of someone with an aneurysm, or offspring. So if your brother or sister has an aneurysm, you're over 60, your parents have an aneurysm, you know, you probably, now these are guidelines, which are different than what insurance or Medicare will pay for, okay? But this is a guideline, so everyone agrees, that's class 1. Everyone agrees that if your mom and dad has one, your brother or sister have one, you're older than 60, you should get an ultrasound. If you're between 65 and 75 and you're a man and you've ever smoked, and that's 100 cigarettes in your lifetime. So they come in and say, yeah, when I was a teenager I smoked. Well, did you smoke 5 packs? I think 20 is, yeah. That counts. That's pretty impressive. I mean, you could have smoked 5 packs of cigarettes 50 years ago, your risk is increased. And the things are still legal.
But Medicare pays for that really well, that second one.
We'll get there. We'll get there. If I don't, remind me, we'll come back to it, but I'm sure you. The answer is yes. So, the thing about aneurysms is the shear force on the wall of the artery gets bigger. The bigger it gets higher. The bigger the aneurysm is, the thinner the wall becomes. You know, the more basically pressure per square area, the rupture goes up. And the rupture is not linear. It's exponential, right? So, just focusing on the top line, we pick 5.5 as the size that we should intervene on, meaning get surgery or a stent. The reason is your risk of rupture below that is less than the risk of the procedure. Above that, your risk of rupture is higher than the risk of procedure, right? So at 5 centimeters, 5.5 centimeters, your risk of rupture starts to grow pretty quickly, and it's significant. And once again, if it ruptures, you die. If it's expanding quickly, that's a risk factor for rupture. So 0.5 centimeter in a year, okay? So you got that guy who's got 4.5 last year, he comes in a year later, he's at 5. Well, he's not 5.5 yet, but he increased by 0.5 centimeter a year. I usually fix those guys, okay? If you're a smoker, your risk of rupture is higher. If you have COPD, your risk of rupture is higher, especially if you're COPD and chronic steroids. If you have a family history of ruptured aneurysm, your risk is higher. Uncontrolled blood pressure. And the shape is important. So fusiform are those nice, comes down, you know. Saccular is just sticking out to one side. Okay? Those are more worrisome. Saccular is more worrisome for rupture. Men get them more often than women. But if you're a woman, you got it, you're more likely to rupture. So the risk of rupture is higher in a woman. The incidence is higher in men. So why is it so important to screen? So if you look here, if you turn this on the side, this is that exponential growth I'm talking about. I mean, it's not stepping up like this. It's stepping up like that, right? So if you're 4 centimeters, your risk of rupture is pretty low. It's safer to watch it. You know, patients always ask, "Why just fix it now?" Well, you know, actually that's more risky than just watching it. But once we get up to 5, you can see that 5-year rupture rate's 25%. If you go up to 7, so it's 2 centimeters bigger, 75% are going to rupture in 5 years. So the data is, if you have an aneurysm 5 centimeters or bigger, 50% of people are going to be gone. So to say that again, if your aneurysm's 5 centimeters or bigger, and you do nothing about it, half those people will be dead in 5 years. Okay? Once again, what we said before, mortality 70 to 90%. Half of them die before they get to the hospital. Half of those that get to the hospital die. And hopefully I have the screening slide. If not, we'll find it in another lecture. So 5.5, we're just talking about infrarenal abdominal aortic aneurysms in normal people. We're not talking about anything weird like Marfan's or anything, but 5.5, keep that in mind. If it's that big or larger, we should repair it. If it's increased, well, let's just go down. Next bullet point. Greater than 4, I check them every 6 months. Those are the guidelines. 3 to 4, once a year. So 3 to 4, they get an ultrasound of their abdominal aorta every year. 4 to 5, every 6 months. I don't do this 2 to 3 years. I do it every year. I'm less than 4 centimeters. So asymptomatic patients, less than 5 centimeters. Really, if you're fixing those, you're putting them, the complication rate of fixing those is worse than the rupture rate, right? So you're doing a disservice to them. You don't fix small aneurysms. I'm thinking about that.
No, I'm thinking about, other than rupture, how would you be symptomatic?
Sometimes people come in with a rapidly expanding aneurysm. They may have back pain.
Okay.
Some people have what are called penetrating atherosclerotic ulcerations or aorta, and what associated with the aneurysm may be. But I mean, if someone comes in with unexplained belly pain and they have an aneurysm,
Okay.
you got to think about, if you don't have another reason, maybe you got to fix them. These are risk factors. Okay. You know, these days most people get endovascular aneurysm repair, a stent graft, rather than going to surgery. But really, if you have a young patient with no comorbidities, they may be better served by biting the bullet and getting an open repair. Okay? When you get an endovascular aneurysm repair, we got to monitor that stent annually, basically for the rest of their life, and that's a CT angiogram. It's a lot of contrast, that's a lot of radiation, right? And radiation builds up over time, your risk continues to increase. So if you got that 50-year-old guy with no problems, those are the guys I, grit my teeth and send them to the surgeons. But, that's probably better for them. And he's looking at, 40 years of CT scans. That's probably going to fix his aneurysm but give him cancer, right? So we kind of talked about this. Okay. So that's a typical angiogram before and after. Got that from Jody. So let's, where are we looking for time? I'll stop whenever you guys want me to.
Hey, just run through the procedure of EVAR. Tell me how I prepare the patient, what I expect afterwards, what you do in the lab.
Mm-hmm. Do that right here.
And I have a screening question, because I actually was going to text you today. I saw a 24-year-old girl yesterday in Macomb, and her mom had an aneurysm, abdominal aneurysm in her 50s. So when are we going to want to look at her? I mean, I'm getting a coronary. She has a lot of family history.
Family history.
And
I usually just do it at age 50.
okay.
Okay?
Okay.
But I know you're recording this. But sometimes you really want to do it. You press real hard, you feel something, right? I mean, to be honest with you, sometimes I say, you know what? I don't care what they're going to pay for or not. Maybe you fib a little bit and say, they got a pulsatile abdominal mass and you're going to get an ultrasound. Right? I mean, sometimes you just got to do what's best for the patient. And Yeah, but
It just feels like at 24, I'm probably not gonna find much, but when
Right.
would I maybe, you know, because her mom's in her.
but you want to talk to them about family history because there is a familial component. And we
Right.
see it a lot in thoracic. We had that.
Yeah.
What's her name? Just talking about it the other day. You know what I'm talking about.
Yeah.
We had the
Yeah.
thoracic that almost ruptured.
How old was she?
Powell.
Yeah, Paula. Oh, that was a scary story. To diverge for a second. She had a family history. I think his sister who had an aortic dissection. Went to a local ER, not ours. Was pregnant with chest pain and knew she was going to die. They told her it was in her head and sent her home. She ended up in our office. Like a day later, we did a echo, and her aorta was like 6.5 centimeters. We did a CT scan. It was a big dissection. She had dissected, and they sent her home.
They didn't even scan her? Oh, because she was pregnant. They were like,
Yeah,
they didn't do an
Remember that?
thing.
Yeah.
Wow.
She was mid-30s, I think.
yeah.
Really
Wow.
young. Yeah.
Oh,
She
yeah.
works for HSHS too.
Oh yeah, she works for for.
Yeah.
Anyway.
Hey, Dr. Goldstein, that rapid they just called was on Murdoch.
No shit. For what?
Yeah.
You want to run up there real quick? Or
Yeah.
just give me a shot.
Okay.
I think I have a key here. Will you give me a call when you get there?
Yeah, I will.
Nobody's. Thank you.
Well, this 24-year-old lady has a lot of family history in all over the place, all different things. Her dad died of an MI at age 31, and
Oh my gosh.
this is crazy. Now he had been in the past a cocaine user. And stuff.
Can you get a coronary CTA?
I'm getting
Would that show
what
the
I'm
aorta?
getting for her is a calcium score.
Let me. Let's run through a few things real quick. This patient actually is Melissa's father-in-law.
Ooh.
In with a hip fracture. You can only imagine. So let's. We'll go through this real quickly. I'm gonna run up and check on him. But I mean, this is a patient that completely asymptomatic, had life screening, and had a 5 centimeter aneurysm. Here's a CT scan. If you look in the middle, I can't read those numbers. I think it says 55.8 millimeters. Okay? What you see there on the bottom right is the aneurysm. The white is the blood flow. The dark gray is thrombus. So, we get a lot of consults, the primaries get freaked out about that thrombus. There's always thrombus in an aneurysm. Abdominal aortic aneurysm, they don't tend to embolize. They're always there. I mean, it's not like, oh my God, we gotta do something about the blood clot. We're more worried about the size. So, almost all of my patients, currently, I do percutaneous. So the same way we do TAVRs, even though it's large bore sheaths, we don't have to do a cut down. We do a percutaneous. I do it under conscious sedation, so they're all awake talking. And a quick EVAR is an hour, a long one's an hour and a half. So, but this is how it happens. So here's an angiogram on the left, on the right is animation or cartoon. But we're coming up from both sides. And you can see here on the left, on the right screen, right side of the screen, the main body of the graft. So you see how it looks like a pant leg, and one of the legs goes all the way down the iliac. The other pant leg's hanging out in the aorta, in the aneurysm. And we put a wire up through that pant leg, and we put the next components, so they kind of interlock, if you will, they overlap. And by doing that, we can build the graft. Okay? And that's the end of the procedure. We won't talk about thoracic aneurysms, but same thing, we can treat those with stent grafts. We talked about aneurysms.
And then they go home on what?
You can just send them home on aspirin. I usually just do aspirin and Plavix. I do their first CT scan at 3 or 6 months, usually 3 months. A lot of physicians do a CT scan at 1 month, 3 months. I do it at 3 months. If it looks good, I start doing it annually. What we're looking at there is with the CT scan and we don't want to see any contrast getting into the aneurysm sac. So what you're doing is I'm getting a seal above, I'm getting a seal below in both iliac arteries. I'm taking the pressure off the wall. If there's a leak, so pressurized blood's still getting into the aneurysm sac, I haven't done anything. You still got that pressure pushing on the wall, it's still going to expand.
Is that the endo leak that?
Endo leak. So most commonly what we see is a type 2 endo leak. If you have a type 2 endo leak, but the aneurysm size is stable or getting smaller, you're okay. If you have a type 2 endo leak and the aneurysm continues to increase in size, you got to do something because you haven't done anything.
So can you go back in endovascular and repair that?
Yeah. Sometimes you can find, so usually a type 2 endo leak is like a little, you know, lumbar vessel or something like iliolumbar, so a vessel that's coming, that went from aorta to iliac, and now you've occluded basically the aorta. You get backflow, and it's pressurizing that. So that's a type 2 endo leak. There's a feeder vessel.
So you just coil that out.
Yeah. They're hard to find, so, but yeah. So, right, all these famous people had aneurysms. Roy Rogers is the only one that survived his rupture. Right, that's what we said, 75%. So if you look at the red, those are the number of people who are at risk for aneurysms. The little green dot is the number of people who are treated. Right?
That's crazy.
Yeah. So we're really, that's why I harp on it so much. I'll show you in a second. There's your 50% die in 5 years, 13th leading cause. More men than women, but women rupture more often. Risk factors: smoking, 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 and then family history, age, everything else. Okay, here's most important, another important take home. If you look at this, just focus on one side. Let's say the men who are older than 60, who have had bypass, their risk of having the aneurysm is 9%. If you're a man over 60 and you've had bypass and you continue to smoke, 20%. You know any patients like that? Same thing with women, right? So the general population, you're talking about 5%. But at pericardiovascular patient, fifth floor clinic, you're talking 20% have an aneurysm. So, size matters. Once again, I'm not going to go through that. So, why is it so important? If somebody has a ruptured aneurysm and we try to repair it, their mortality is still 70%, right? Half of them come to the hospital and die. If I electively fix somebody, their mortality, let's just say, is 5%. It's probably lower than that with EVAR, right? So, if you can screen the patients, find them, treat them electively, you've taken their mortality from 70 to 5%. I challenge you to think of any other therapy that, right? So, aneurysm rupture can be avoided by identifying the population risk and conducting non-invasive examinations. So, this study, what they did is they took people at risk and the treatment group got screened, the control group didn't get screened, and then they followed them for 5 years. The control group, the darker purple, you can see in 5 years their mortality was over 20%. The screen group was less than 5%. So all they did, the only intervention they did was do an ultrasound of their aorta, and they decreased the. So if you got patients at risk, you do that one ultrasound, which is free, you're saving lives. That's why it's so important. So this is ACC, Society of Vascular Surgery. Let's just go to, you've all seen this, but this is what Medicare will pay for. Oh, just to back up, this is what Medicare will pay for. We were talking about Danita's patient. Everyone focuses on this with aneurysms. If I order an aneurysm on Amy, a duplex ultrasound on Amy, your insurance, you know, whatever, is gonna pay for whatever, you'll have a copay. It's the same as any other study. If I order carotid duplex, a stress test, an echocardiogram, everyone gets hung up on, well, you're gonna have a copay. But we never think about it for all the other, every test we do has a copay and a deductible and everything. So you can order the test on whoever you want. Their insurance is gonna pay for, you know, what they'll pay for, and they're gonna have a copay. The thing with Medicare, there's no copay, right? So it's funny how everyone worries about that, but we never think about it. We order stress tests out the ass, and you know, patients. My neighbor got one, and got like a $3,000 bill or something. Anyway, so 65 to 75. You're a man. You've ever smoked those 100 cigarettes? Medicare will pay the whole thing. Man or woman with family history of abdominal aortic aneurysm. I didn't put an age in there. I believe it's 50, Danita. But if you're worried, just order it.